So some of the goals of coordinated entry, just a quick recap, are to lower the barriers and make access to housing as streamlined as possible so that unhoused folks are able to get reconnected with permanent housing as quickly as possible. Another goal is to be really clear and transparent about what services are available and how likely folks are to get connected to them. Another goal is to make sure that everyone who comes in has the same experience in terms of the assessment so that everyone's on equal footing coming into the system. We also want to prioritize folks who are most in need of assistance and match them to housing that's going to be the best fit for them. As you already know, and a reminder or a refresher, the current approach for assessing folks and prioritizing them is largely based on the Vulnerability Index Service Prioritization Assistance Tool, so the VI-SPDAT. Folks are prioritized based on their scores on this assessment. And the VI-SPDAT asks a lot of questions. Folks are asked questions about whether they've ever threatened to or tried harm to themselves. There's really tough questions about things that are considered risky under the assessment. So exchanging sex for money, running drugs for someone, having unprotected sex. The assessment asks about drug use and drinking and all of these really invasive questions that folks that are in a crisis are having to answer to be placed on the queue. And the simple description is that people with higher scores are referred first, but we know that we have those couple bands. There's the permanent band of folks that get prioritized for long-term housing assistance, and then the short-term housing assistance. And within each of those blocks, people who have higher scores get prioritized first. So why are we talking about redesigning this whole process? Some of the challenges that we've heard both from unhoused folks that are going through the process of trying to get connected to housing, and also providers that are partners in the system, are that we know there's not enough housing beds. We know there's not enough supportive housing for everyone who needs it and who could benefit from it. And we are asking a long list of really tough questions that force people to expose their whole history, and questions that are really tough to answer for folks that are in a crisis. And we also know that because there's not enough beds, a lot of folks that are taking this assessment won't actually get a referral to permanent supportive housing or rapid rehousing or transitional housing. The majority won't get a referral. But it can feel, if we have assessed someone and we've put them on the queue, it can feel like, okay, we've done everything we can. They're on the queue, so now it's out of my hands. So we wind up with a system where a lot of folks are sitting on the list, and neither providers nor unhoused folks know if or when they'll ever get a referral through the system. We also don't know if the folks that are actually getting referrals are the folks who need the most support. So those are kind of some of the challenges that we've heard in our past meetings. So what can we fix? Which of these can we possibly fix through the redesign process? The redesign process it has the potential to lessen that burden of invasive questions. Can we get rid of some of these really tough questions that ask people to spill their entire life as they're in crisis? So we can lessen that burden on unhoused folks and on providers. The redesign process also has potential to create a clearer, simpler, more transparent system that'll provide more transparency about who will and who won't get housed through coordinated entry. It can also, or one of our goals is to really improve equitableness of referrals to, overcome some of the disparities that we see in terms of who experiences homelessness in Santa Clara County. Finally, the redesign process definitely has potential to create a system that's more effective in prioritizing folks that need the most support. Being mindful of what the coordinated entry redesign process will not do, it will definitely not increase the supportive housing supply. So when we're talking about redesigning the assessment or prioritization, that will never change how much housing there is in the system. So for folks that are interested in those conversations, that will be done through the implementation of strategy 2 of the community plan to end homelessness. And Nicole, maybe you can pop a link to that in the chat right now. The other thing that coordinated entry redesign will not solve, it won't reduce the number of folks that are falling into homelessness. So this is another thing that we're hoping to address through the community. We're aiming to address through the community plan to end homelessness, and that's what really strategy 1 is about. So being mindful of the things that we can achieve and can't achieve through the redesign process, I think will be really important to making sure we're simplifying it and getting rid of as many burdens on unhoused folks and providers as we can, because the coordinated entry redesign alone will not solve the supply issues. With that in mind, some of the goals that folks have identified in the last meeting and in some of the prep meetings that we've had with y'all are really wanting to make sure that throughout this redesign process that we're centering lived experience and equity, and that the decisions that we make are evidence-based and they're clear and transparent, and that there's communication and engagement with the community throughout the redesign process. So we're going to spend some time in a little bit talking about what will that community engagement process look like? Who's going to drive this work forward? Who do we want to make sure that we hear from to create a new coordinated entry process? Another key value or key goal that we've heard loud and clear is that the assessment process is way too long and the questions are really intense. So we really want to be aiming for shortening the process and as much as we can, minimizing re-traumatization. One more goal is to create a prioritization and a referral process that works for everyone, that supports all folks experiencing homelessness, regardless of their demographics or their subpopulation. Great. So what does it mean when I say that we want to think beyond assessment? What does it mean to think bigger picture when we're talking about redesigning coordinated entry? We really, again, want to avoid pinning all of our goals on assessment alone. So sometimes the goals that we try to reach through assessment might be better suited to be addressed through prioritization or through referral, which can be kind of more nimble parts of the coordinated entry process and can be easier to adjust to respond to changing circumstances or community needs. So when we're thinking about redesigning assessment, we really want to step back and think about what is it that we're trying to prevent with supportive housing. So I think I saw someone already getting at this in the chat, but how do we actually define this super vague term of vulnerability? Like, what does that mean to Santa Clara as a community? Is it the likelihood that someone will experience long-term homelessness? Is that what vulnerability means? Is it how likely someone is to have physical or behavioral health crises? Is vulnerability the likelihood that someone will be involved in the criminal legal system? So we really need to think about, how do we define vulnerability in our community? Once we've figured that out, once we've created a definition, then what are the questions? What are the fewest questions? What are the questions we need to ask of unhoused folks to try to predict the likelihood of these experiences or results? So if we define vulnerability as someone experiencing long-term homelessness, of not being able to get out of homelessness, then what do we ask about to try to predict that? Do we ask about history of housing instability? Like, what are the factors that get at some of the outcomes that we're trying to avoid? Another thing to think about in the context of redefining assessment is there room for assessor discretion? The tool right now is based entirely on self-report, but is the system we want to set up one where self-report is part of the process and there's some room for staff input? Or do we want to stay with the same approach where assessment is only based on client responses? Unpacking prioritization a little bit, we want to step back and think about how we match folks, or how we prioritize folks for housing. So who's going to make it on the community queue? So right now, the bar is very low. So the vast majority of people who take the VSPDAT assessment are placed on the community queue. So we have this massive community queue, thousands of people, where 95% of those folks will never get referred to housing because we just don't have enough supply right now. And 100% of unhoused persons that are on the queue and providers in the community are frustrated with the complete uncertainty about folks' chances of getting housed off that list. So how do we want to structure the community queue? When we're thinking about redesigning prioritization, does it make more sense to have a shorter community queue where fewer people make it on the list to begin with, but we know that everyone who's on the list has a 95% chance of getting housed within 3 months, and every unhoused person who's part of coordinated entry and every provider knows exactly how likely someone is to get housing through the system? Does it make sense to have permanent supportive housing and rapid rehousing prioritization bands? What would it look like? What could it look like to prioritize all supportive housing openings the same way, to get rid of that banding that creates a donut in who's served? What should the prioritization criteria be? Is it just the assessment score? Is it some sort of formula or layering of the assessment and how long someone's experienced homelessness, or whether they're unsheltered, or whether they're chronically homeless? Is there certain prioritization for subpopulations? Like, do we as a community want to prioritize veterans or young adults or older adults or domestic violence survivors. So these population related decisions could, they could be made on the prioritization level rather than the assessment level to be able to simplify the assessment piece. And in terms of redesigning the referral piece, we can be thinking about subpopulation specific set-asides. So we know that the demographics of the homeless population are far from static, and the demographics are always changing, and referral can be a more flexible way to meet these needs, as for example, the population experiencing homelessness ages, and also as unforeseen circumstances like COVID come up. So if we know, for example, that X% of the population of experiencing homelessness in Santa Clara County are young adults and Y% are survivors of domestic violence, sexual assault, human trafficking, and Z% are older adults, then can we set aside certain resources in proportion to those needs? So do we want to allocate more resources to certain populations because we've decided as a community that we want to prioritize them? Again, this is just kind of an example of ways that we can get at some of our goals on the referral level or on the prioritization level to streamline, to help us get to the goal of shortening the assessment process and minimizing re-traumatization. Another piece that I think is super important to consider as we're thinking about redesigning the referral is how does client choice fit in? Like if we want a person-centered system, what does that look like? What is it, if the people closest to the issue are closest to the solution, what does it mean to build more self-determination into the coordinated entry process to empower folks to make informed decisions about the types of programs or the types of services that they would actually thrive in? So that's a lot to unpack. And again, this is to give you a sense of we're really thinking beyond assessment in terms of the coordinated entry redesign and wanting to look critically at all of the pieces of the puzzle. So with that, we're actually going to shift gears and share, I think one of the first questions that folks typically have in visioning situations like this is, what are other communities doing? How have other communities, we know that every COC has to have a coordinated entry process, and a lot of COCs are coming to terms with the VSPDAT not being the ideal way to assess folks, to say the least. And what are other communities doing? So we're gonna recap the Allegheny County presentation, or Allegheny worked with Auckland University. They came to present at the last meeting. We're just going to do a quick recap of the information that they shared. Folks are welcome to also view the recording from that meeting. I've shared it through the SPN listserv and the COC listserv, and I'm happy to email it directly to anyone. We'll also talk about two other examples. There's a number of communities that went through the Housing and Urban Development Department's recent coordinated entry equity demonstration. So we had a chance to connect with these communities, the two of them that focused on assessment and prioritization redesign were Chicago and Hennepin County. So we'll be sharing with you what they've done to redesign coordinated entry. After that, we'll stop talking and ask you to brainstorm the pros and cons of each approach. We've come up with some. really want to hear your thoughts on them and any other ideas for how to approach the redesign process that you may have. So what did Allegheny County do? So Allegheny County worked with Auckland University to create a new tool based on their own data. So this Allegheny County Housing Assessment, the AHA, it predicts the likelihood of 3 adverse events occurring in someone's life if they remain unhoused for 12 months. So this is how they defined vulnerability, essentially. They defined vulnerability as someone experiencing a mental health crisis, so which is indicated by a mental health inpatient stay. They also define vulnerability as someone being involved in the criminal legal system. So they further define that in the data as a jail booking, or someone having a physical health crisis, so going to a hospital emergency room. So the mental health inpatient stay, the jail booking, and the emergency room visits, they kind of serve as indicators of harm, that these are things we want to prevent. We want to prioritize folks, or Allegheny County wants to prioritize folks who are at higher risk of these things happening. So basically, the AHA assigns a risk score that's used as part of the prioritization process. And it's used along with a set of rules. So it's not just, the assessment, but there are a set of prioritization rules that guide who gets placed on their waiting list and who is referred to housing. So that vulnerability or a need for support, that's measured by the AHA score and someone's history of chronic homelessness. So then the highest need folks on the waiting list will be the first to be offered an available bed. Folks that have no chance of getting a referral through this process are never placed on the list. So if your score is super low, if the tool predicts that you have very low likelihood of having a mental health inpatient stay, very low likelihood of having a jail booking, very low likelihood of using a hospital emergency room, then you never go on the list to begin with. So of course, that doesn't get rid of any eligibility criteria that programs have, right? So specific types of beds. So maybe there's family housing, there's youth housing, there's specific types of resources, obviously still have to be filled by folks who meet those eligibility criteria. How did they set up this model? So the short of it is that this predictive risk model, to create the tool, the way they've set it up is first defining vulnerability. So identifying those outcomes that we aim to prevent through supportive housing. So in their case, again, the mental health crises, physical health crisis, criminal legal system involvement. So asking, how do we measure those outcomes in the data that we have? So mental health crises, they measured with mental health inpatient stays. Criminal legal system involvement, they measured by jail bookings, and physical health crises, they measured through hospital emergency room use, right? So then the Auckland University folks used statistical analysis to look at all the data that the community has collected about those outcomes, and about and all the data they had collected through the BI-SPDAT and through their data warehouse, to identify which experiences, which factors are actually tied to those outcomes. Where are the correlations? Which questions are relevant and don't predict whether you'll experience a mental health crisis, or which questions tend to, if you say yes, it's significantly more likely that you're gonna be using a hospital or emergency room frequently. So finding those factors that correlate with the outcomes that we're trying to avoid through statistical analysis. So this model is trained on local data with a local definition of vulnerability. And then they narrow the assessment questions just to focus on the factors that that relate to those outcomes. And finally, of course, it's testing for accuracy and equity. So basically, again, to recap, the approach is community driven and defining what outcomes are we trying to prevent, and then really digging into data analysis and finding the evidences of factors that are correlated with those outcomes, and narrowing the assessment process to just those things that are predictors of the types of harm that we want to prevent. So some of the what they found in the model is that it's much more predictive than the VI-SPDAT. So what this chart is saying basically is that no matter if we follow the jail line, the blue line, no matter what score you get on the VI-SPDAT, it's not predictive of whether you have a jail booking. Like 10% of people with 4s on the VI-SPDAT have jail bookings, and 20% of people with 13s and more do. The same for ER visits and mental health inpatient treatment. No matter what score you have on the VI-SPDAT, your likelihood of experiencing these events that we're trying to prevent is practically the same. And what the customized tool allows is, again, having a community conversation about what are the things we're trying to predict. In Allegheny County's example, it was these 3 things, and creating a process that actually predicts how likely they are to happen. If you have a low score on this locally created tool, then you are very unlikely to experience these adverse outcomes. The higher your score is, the more likely you are to have a jail booking, to have a mental health inpatient treatment, to wind up in the ER for more times. So the tool is effective at predicting the outcomes that the community wants to avoid, and that's the way that they use it for prioritization. I want to pause for questions here before we move to another example from Hennepin County.
Sasha, Marjorie has her hand raised and she dropped a concern in the chat.
Well, the chat is very long. Oh, the one at 141? Marjorie, is that what you wanted to raise right now?
Actually, well, I mean, that was in the chat, so, you know, it's there. My question though is, like, if we were to adopt a predictive risk model for prioritization, yes, I did. I expressed my concern about that, but I mean, would would we be stuck in that, or would we be able to add questions that, and put weight on, length of time homeless and stuff like that? Because as I said, there are going to be people, and in my experience with homeless services, I run into a lot of people who are chronically homeless whose scores could typically go down because they learn how to avoid the police. They learn that going to the hospital, people, especially if they're an addict, they go to the hospital, they're not going to get medical care. They're going to get told to stop using drugs rather than having their needs met. And so, you know, I was just wondering, you know, I mean, is it a possibility to kind of blend a model where you have we do go with the prediction, because I think that that's valid, but we're also looking at, you know, the actual, like, you know, we're not discounting the fact that we're going to have a very high population of people who are not going to blip on that radar.
Totally. And I'll answer your question on kind of two levels. So first, yes, there is, this is where we need to keep thinking about what is achieved through the assessment and what is achieved through prioritization. So for example, Allegheny, yes, they have this assessment, but they are still prioritizing also by history of chronic homelessness. So there are opportunities, you know, again, what do we want the assessment to do? And what do we want prioritization to do? And there's room for, and we want to re-examine both. Your second question though, or I guess the same question is, these questions, the goal of the model is to predict these outcomes. It's not, the questions aren't, have you been to the ER 4 times? Have you had a jail booking? Because like you said, you know, folks are resilient and have found ways to avoid those. It's how to predict those poor outcomes. So what questions do we need to ask about folks' experiences that predict a jail booking? So it's not have you experienced one, but how, you know, what circumstances, what outcome, not outcomes, what factors make it more likely that you will have a jail booking? How is the person doing the intake able to assess a client's mental health? Yeah, so again, 2 layers of this. In Allegheny County, they have left some room for an override, as they call it. So they've left some discretion to assessors to, you know, to have like a judgment call on some of these questions, and to say like this, you know, this client, I've worked with this client, like I know they've experienced this type of trauma and they're like not able to answer this question in a way that reflects, you know, their actual experience there because of the trauma they've experienced. So they've left some room for assessor judgment. So that's like one way to get at that. I think the other piece of this is really honing in on those questions that, based on all of the data that the community has collected, and in Santa Clara, that's like 6 years of data in HMIS right now. What are the questions that we're asking that seem to, you know, that statistically predict the outcomes we're trying to avoid? Okay, I want to make sure that we have time for the other community examples, and we'll have kind of more opportunities for open Q&A later. So I'm going to pass it to Nicole to talk about Hennepin County and Chicago, and then we can all have a conversation about the pros and cons of the approaches. That sounds good to folks.
Thanks, Sasha, and thank you, Laura, for that segue to talking about what the other,
I'll share, sorry. Click the wrong thing.
Models are. So we'll start with Hennepin County. and Hennepin County, as Sasha had mentioned, was part of that HUD equity demo. So Hennepin County has always prioritized based on disability status, chronic status, and length of time experiencing homelessness. What they did is they had factored in the VI SPDAT scoring. And so through this process, they have removed the VI SPDAT altogether from the equation. And now their criteria and scheme prioritize based solely on disability status, chronic status, and length of time experiencing homelessness. So what this looks like is when they're looking at the priority list, everyone with a yes to disability status is at the top of the list. And then number of months of HUD months homeless is what the tiebreaker is. And they're currently working on identifying a series of questions to capture medical fragility that's going to replace the disability status question. And this is a direct response because the community was concerned that the disability status question was missing nuance and fully capturing vulnerability. So they're developing a short series of questions that are going to have a more expansive view of medical fragility. And with Hennepin County, they've applied this new prioritization process across all their program types. And so Sasha briefly alluded to in terms of what prioritization redesign can look like. With Hennepin County, they have done away with those banded intervention ranges. And I'll speak to that a little bit more in a couple of slides. And they've also done something we think is pretty innovative with adding a client choice section, which explains program models and then asks questions regarding client preference, and that's factored into the referrals. And we'll see a few slides actually showing you what that client choice section looks like. And just in transparency, they have some data in terms of what the outcomes have looked like since moving to this scheme, but they're still waiting until April, to be specific, to collect a little more data to fully test equity impacts. So on the next slide, you're going to see what the client choice section looks like. So after incorporating the HMIS assessment component that really looks at the disability status and length of time homeless, and then after the assessors have assessed for eligibility, a series of client choice questions are asked. So here we see there's a question around locations. So it asks clients if there are specific communities that they can't live in or they prefer to not live in. And this factors in, if they're DV survivors or if their children are enrolled in certain school districts. And then they also have a section that's a section of culturally specific questions. So asking if culturally specific housing is important to them to maintain housing. If so, which community, and if it's important for them to have a case manager who's familiar with that culture. And that was a direct response and addressed a lot of, so in Hennepin County, there's a significant Indigenous community, and they were really concerned and thought this was very important to have. And so the community responded and addressed that by adding in this section in particular. And then on the next slide, we're going to see what it looks like. So within the client choice section, assessors will see these pop-up boxes that provide further information. And Hennepin County has found this element in particular to be a game changer, really important in allowing clients to be more informed when making these preference calls. So after someone is assessed for eligibility, it's determined that they would be eligible for rapid rehousing or permanent supportive housing. The client is asked which housing they'd like to be referred to if there's an available opening. And you'll have these pop-up boxes that explain what permanent supportive housing looks like and what rapid rehousing looks like, so they can make that determination. And then you'll see more toward the bottom of this screenshot that, again, if they're eligible, they can select whether, after learning a little bit more about the model, they'd only like to opt into PSH, or they'd like to be on the queue for both PSH and rapid rehousing. So if the next available opening is one or the other, they're fine with that, they want to accept either opening, that's an option for them. So it's really client steered and guided in that sense. Who would choose? So first, the assessor has to, first, it's a matter of whether you're eligible for either option. But if they are eligible for both, then, and they select, I don't have a preference where I think I could only succeed in permanent supportive housing, or I only want rapid rehousing, then it's their choice and they get the next opening that's available to them, if that makes sense. And then on the next slide, we're going to see a couple more questions that are asked. And these questions, through piloting the client choice section, they realized that beyond just asking whether a client would like a rapid rehousing or a PSH opening, there were other elements that really mattered to clients in terms of, is the project site-based? Is it scattered site? Is there a front desk? Is this program going to have a real focus on substance abuse? So there were a series of questions that were added in to cater to that. And again, you see there are those pop-up boxes that explain some of these housing options in further detail so that they can make an informed decision. And from Hennepin County's perspective, the framing around this was really to get at what are clients' bottom line? What are they not willing to take? It's not necessarily framed as what's your ideal choice, but would you accept an opening of the following description? Okay, so I'm now going to stop here and see if there were any questions. So do I have an example of who they would offer both to? So again, it is if you're eligible, so if the person is eligible to receive a referral to this, they then choose at the bottom the PSH, the rapid rehousing, or both PSH and rapid rehousing. And if the next opening, if they've selected both PSH and rapid rehousing, if the next opening is rapid rehousing, they're going to get that one. Am I answering your question, Laura?
Yeah, no, you are, I guess, and maybe it's because I'm trying to wrap my head around how that would work, right? Because right now we very singularly say you're either eligible for PSH or you're eligible for rapid. Rapid is time limited. I think to Marjorie's point, who would take rapid if PSH was available? I also know people who want PSH, but at least currently how we prioritize people aren't eligible for it and they wouldn't meet HUD's eligibility criteria. So I'm just trying to understand how they were looking at that, or maybe they're using programs that are not HUD funded and things like that, just to think of. I think I have a concern about that. If it's whatever's the next available, are we putting people in housing that it's not realistic for them to maintain because rapid rehousing is time limited? And I could also see somebody thinking well, yeah, I'll take the rapid rehousing because, I'm going to do all these things, but sometimes it doesn't work out that way, depending on what their individual challenges are in life.
Sure. So, and I think KJ's already got into a bit of this in the chat. So they don't have that banded intervention major. It's oh, you scored a 14, this is where you're slotted. So they've done away with that. And they've really worked towards a progressive engagement model where you're receiving this, but that's not, okay, this is definitive. If you do need more supports, they've really worked on their transfer policy and how you might move from rapid rehousing to permanent supportive housing or have extended supports to you. So that's how they've gone around that. But I think the reality, and this is we can have an entire COG meeting just on this. So I think we will kind of parking lot this a bit, but it's definitely a conversation that I think keeps coming up. And the reality is there are a lot of people who get referred to rapid rehousing that might have really high acuity needs. And there are those challenges, but for the sake of time, we definitely will be revisiting this conversation at length. But are there other kind of questions about how this model works before we move on to Chicago? Okay, I'm glad that I answered a question you were typing, Marjorie. Okay. So Chicago was another community that was a part of the HUD equity demo, and they had a work group that identified 20 assessment questions and then narrowed that down to 6 questions. And they piloted and tested various scoring options for equity impact. Now they're waiting for COVID to subside to fully implement this 6-question scheme into their criteria. At the moment, they are using solely just using a COVID criteria. So if you're prioritized if you're 60 or above or 12 months and younger, and then the second priority is anyone with a CDC determined high risk underlying health conditions. So that's including but not fully exclusive of asthma, cancer, kidney disease, and their other conditions as well. But the 6 questions that they narrowed it down to are: 1, have you ever in your life spent any amount of time in a juvenile or adult correctional facility, jail, prison, or detention center? 2, growing up, did your family experience housing instability, such as frequently moving due to financial reasons, living with other families and relatives, which is also known as doubling up, living in a shelter, or living in nightly or monthly rentals or anything like that? The third question being, have you ever been discriminated against because of your sexual orientation or gender identity? The fourth question, do you identify as Black, Indigenous, Native, and or a person of color who's been discriminated against because of your race or ethnicity? And then, have you experienced violence in a home where you lived or seen others experience violence in a home where you lived? And that violence can be physical or emotional. And then the final question is, are you currently being hurt or experiencing violence on the streets or in a shelter, or attempting to avoid people who have hurt you since experiencing homelessness? And the process they use to narrow it down to these 6 questions is they involve testing questions really aimed at representing the experiences of Black and Brown people as a way of learning if new questions would be more racially equitable than the current questions that were being used to score people based on need. And Chicago, actually, we can move to the next slide before I say that. So Chicago was using the VI, and then in 2019, they decided the VI isn't capturing the full extent of vulnerability that Chicago would like. And so they began scoring on length of time homeless. And so they would prioritize on length of time homeless, and then the tiebreakers for them were the following. It would be unsheltered status, and then veteran status. The VI score was still incorporated, and then if you were a survivor of DV. And they had and have always had 10% of units in PSH and rapid rehousing as a set aside for youth. So to kind of recap, they used the VI, then they went to scoring with the length of time homeless, and then those tiebreakers. And they are now planning on, again, as COVID subsides, bringing back those pilot questions. But they've also been looking at and are really curious to learn more about other communities that are exploring really weighting and prioritizing a score based on if people completing the assessment are a person of color and if they've been discriminated against on sexual orientation, gender identity, race, or ethnicity. But in terms of models, the Chicago model is the least fleshed out as of now, but that is what they're doing. So I'll stop there and ask if there are any questions on this model. That is the VI, yes, not the VI spit out that Chicago was using. So they felt an even greater urgency to add questions in because the VI is so narrow in its focus. Any questions about Chicago?